CPX-351 is a liposome of two drugs, Cytarabine and Daunorubicin, and they are enclosed in this liposome in a 5-to-1 molar ratio, which has been found previously to be highly synergistic. And there were several trials done developing this drug, ranging from relapsed refractory leukemia to frontline leukemia. And eventually, there was a significant survival benefit that was noted in patients with secondary AML. And that is to say, patients who have therapy-related AML, so AML arising after previous therapy for another malignancy, patients who have AML with MDS-related changes, or those who have a prior history of myelodysplastic syndrome. And in that, based on a phase 3 randomized trial, CPX showed a survival benefit over 7+3, which led to its approval in that subtype of AML. And so, based on, again, on the activity of venetoclax in combination with low-intensity chemotherapy, we hypothesized that the addition of venetoclax to CPX-351, which has been active in AML, could be potentially very active. We do know that patients who had CPX versus 7+3 on that initial clinical trial had lower early mortality and higher response rates. And so we thought that if we could couple venetoclax with this particular regimen, we could potentially maintain a degree of good tolerability and also excellent efficacy. And so the trial is a phase 1 trial, which was started initially as a safety dose escalation. And so we started at a dose level -1, which is to say that we kept CPX at the standard dose, and we gave venetoclax at a lower dose of 300 milligrams daily instead of the target dose of 400 milligrams daily. And that was given on days 1 through 21 of that cycle. What we found is what we would probably expect going in, is that there was prolonged myelosuppression. If you remember from the initial phase 3 CPX trial, there was a prolonged time to count recovery associated with CPX-351 compared to 7+3. So we knew that prolonged myelosuppression was going to be built in, and indeed, venetoclax added a bit more myelosuppression to that. And so the initial DLT was, prolonged myelosuppression greater than 42 days. And so we then decreased the number of days of venetoclax to eventually 7 days at 300 milligrams, and found that dose to be tolerable with good count recovery in that patient population. And so the initial 3 cohorts rather, were with patients who had relapsed and refractory acute myeloid leukemia treated with CPX-351 plus venetoclax. And what we found is that the tolerable dose was 300 milligrams of venetoclax on days 2 through 8, so 7 days, in combination with CPX-351 on days 1, 3, and 5 during induction, and then on days 1 and 3 during consolidation or subsequent reinduction if needed. And among those patients, we had a total of 20 patients enrolled, again, all relapsed refractory. The overall response rates, that is a combination of CR plus CRI plus MLFS, was 44%, with a complete remission rate of 6% in this multiply pretreated population who had a median number of prior therapies of 2. And the median time to count recovery in this entire population after the dose escalation was about 41 days. Patients received a median of 1 cycle. What was very interesting in this case is that in those patients, in this group of 20 patients, the median overall survival was about 6.1 months, but the 1-year survival was 46 months. 7 of the 8 patients who responded were able to move on to allogeneic stem cell transplant. And so it was an effective regimen that allowed people to stay in relatively decent shape and were able to go on to a stem cell transplant. And among those patients who had a complete remission, their median duration of complete remission was not reached, and their 1-year CR duration was 86%. And so we did some further analysis looking at the types of patients that responded in this relapsed and refractory cohort, and we found indeed that patients who had prior venetoclax had a slightly inferior median overall survival of just 5 months compared to not reached in those patients who had not had prior venetoclax. And so now the trial has branched into 2 separate categories, one for patients with newly diagnosed acute myeloid leukemia and those with relapsed and refractory. And so we just branched into that, and we're enrolling to see overall activity and safety.